Welcome back to the Deep Dive. So glad you could join us.
Happy to be here.
Today, we're opening up a file on a topic that is, well, it's pretty much a sleeping giant.
That's a good way to put it.
We are looking at a condition that the medical literature calls nearly ubiquitous. I mean, it is the single most common benign neoplasm in American men.
It really is. The statistics are staggering when you look at them.
And yet, for something that affects this massive chunk of the population, there's just this fog of awkwardness around it. A lot of misunderstanding, and let's be honest.
A lot of bad jokes.
A lot of terrible jokes, about long road trips or getting up in the middle of the night.
Right. It gets reduced to a punchline about getting older. When you look at the numbers, it's not really a question of if for most men, it's a question of when.
Exactly. And that is our mission today. We want to dismantle that punchline.
Get behind the joke.
We are diving into a really comprehensive medical chapter on benign prostatic hyperplasia, or BPH. And the goal here, for you, is not just to get a list of symptoms. We want to understand the mechanics of it.
The why.
The why. Because this isn't just about getting older. It's about a really complex interplay of biology, hormonal chemistry, and frankly, some questionable architectural design choices in the human body.
Questionable architectural design is a very, very polite way of saying it. When you really dig into the source material, into the anatomy, you start to realize the prostate is in some very high-stakes real estate.
It really is. So let's set the stage. We're talking BPH. Before we go any further, let's just strip away the jargon. What are we actually dealing with here?
Okay, so let's just break down the name, because the name itself tells you pretty much the whole story. BPH.
Right.
Benign prostatic hyperplasia. The first word, benign, is probably the most important one for, peace of mind.
Okay.
It means it's not cancer, it's not malignant, it's not going to spread to your bones or your lungs or anywhere else.
Which is a huge, huge distinction.
Yeah.
I think the second anyone hears the word growth or tumor in that part of the body, the mind just goes straight to the C word.
It does, and it's important to know they can coexist, but BPH is its own separate thing. It's not cancer.
Okay, so that's benign.
Then you have prostatic, which is simple enough. It tells us the location, the prostate gland.
All right.
And then the last word, hyperplasia. This is a really specific biological term. It's not hypertrophy.
What's the difference?
Hypertrophy is when cells get bigger. Think about a muscle when you lift weights. The cells swell. Hyperplasia means you get an increase in the number of cells.
This is a population explosion.
It is a literal population explosion. You have a non-cancerous overgrowth of cells, and they're all crowding into a very, very small space.
Okay, so we've got a crowd of cells in the prostate. Now, in my head, and I think for most people listening, the prostate is just this walnut-sized thing that sits there.
Right.
If it grows, it blocks the pipe.
Yeah.
It seems like a simple plumbing problem. A clogged drain.
A clogged drain, yeah.
But the source material we're looking at suggests it's way more nuanced than that. It's not just a clog.
Oh, it's much more nuanced. I mean, if it were just a clogged pipe, the treatment would be simple, right? You just, roto-rooter it out.
Yeah.
But to really understand why BPH behaves the way it does, and especially why the symptoms can fluctuate so wildly from day to day, you have to look at the anatomy. You have to see what the prostate is actually made of.
Okay.
And the text breaks it down into 3 really distinct types of tissue, and all 3 of them play a role in the problem.
Okay, so lay them on me. What are the ingredients here?
So first you've got the epithelial, or the glandular tissue. This is the part that does the actual work of the prostate, producing all the fluids that go into semen.
The factory part?
Factory part. Then you've got the capsule that surrounds the whole thing, kind of like the skin on an orange.
Okay.
But the third one is the real game changer here. It's the stromal, or the smooth muscle tissue.
Wait, hold on a second. Muscle. You're saying there's muscle inside the prostate gland. See, when I think of a gland, I think of, I don't know, a sponge. Or like a little cluster of grapes or something. I do not think of a bicep.
I know, it sounds weird, right?
Why on earth is there muscle in there?
Well, that's the million-dollar question, and it is the absolute key to understanding the misery of BPH. You have to remember what the prostate's job is. It's not just there to cause trouble later in life.
Right, it has a purpose.
It has a reproductive purpose.
Right.
When a man ejaculates, the prostate has to contract vigorously to pump its fluid into the urethra and mix it with sperm. It needs force. It needs to be able to squeeze.
So it's a pump. It's not just some passive little lump. It's an active Muscular pump.
It's a muscular pump, and it's wrapped in a tight fibrous capsule. And this is where the source material gets really, really interesting, because that stroma, that smooth muscle tissue, is absolutely loaded with something called alpha-1 adrenergic receptors.
We hear about receptors a lot. In this specific context, what is an alpha-1 receptor doing? Is it just sitting there?
Think of it like a light switch for muscle tension. The alpha-1 receptor is the switch, and adrenaline or norepinephrine from your nervous system is the finger that flips it on.
Okay.
These receptors control muscle tone. So under normal conditions, your nervous system is sending these little low-level signals to the receptors, basically saying, stay tight, be ready, maintain tone.
So you're telling me the prostate is basically in a constant state of low-grade clench.
Exactly. It has tone. Now, let's use an analogy. Imagine a garden hose. That's your urethra, the tube that carries urine out of your bladder.
God.
Now imagine you wrap a muscular fist around that hose. That's your prostate. If that fist is just sort of resting there, water flows through pretty well. But what happens if you increase the signal to those alpha receptors?
The fist tightens.
The fist tightens. The hose gets pinched. And this, right here, leads us to the absolute core concept for understanding this entire condition. The source text calls it the two factors.
Okay.
The static factor and the dynamic factor.
Let's unpack those, because it sounds like this is the roadmap for how we're going to treat it later on.
It's the entire roadmap. So the static factor is the obvious one. That's the hyperplasia we talked about. Physical growth. The gland just gets bigger over years and years. The cells multiply, the mass increases, and it physically crowds the urethra. It's like the walls of a tunnel slowly getting thicker and thicker.
It's the plumbing problem, the slow clog. I get that.
Right. But then you have the dynamic factor, and that's the muscle tone we were just talking about. That is the fist clenching.
Okay.
And here's the kicker. Unlike the growth, which takes years to develop, the dynamic factor can change in minutes.
Minutes. How?
Because it's driven by your nervous system and by these receptors. And this is what explains why a man's urinary symptoms can be great one day and terrible the next. If he's stressed, if he's cold, or, and this is so critical, if he takes certain types of medication, that muscle tone can spike. The fist can clench down hard.
This is a huge aha moment for me. So the problem, the obstruction, it isn't just because the prostate is big.
No.
It's because the prostate is actively squeezing the tube that runs through it.
Precisely. The size determines the potential for obstruction, but the tone determines the reality of it, moment to moment. And this leads us directly into what our source material talks about next, which I call the medicine cabinet danger zone.
Yes. I was just about to bring this up. The text had this list of common drugs that can essentially trigger this clench. And I want to put a giant red flag here for anyone listening.
Please do.
Because this scenario sounds like an absolute nightmare. Let's say you're a guy, you're in your 50s, maybe early 60s, you've got mild BPH, you wake up maybe once a night, the flow is a little slow, but it's manageable, you're fine.
A very common story.
Then you get a head cold, a nasty one.
Yeah.
You walk into the pharmacy, what happens next?
Okay, so you walk into that pharmacy, you're congested, you feel miserable. You go to the cold and flu aisle, and you grab the box that says maximum strength sinus relief. Specifically, you're probably looking for a decongestant. The D in all those product names.
Right, pseudoephedrine or phenylephrine, the stuff that actually works to clear your nose?
The stuff that actually works, but you have to ask how it works. These drugs are alpha-adrenergic agonists.
Agonists, so they stimulate the receptors.
They stimulate them. They work by telling the alpha receptors in the blood vessels in your nose to constrict, to squeeze. That shrinks the swollen tissue, and presto, you can breathe again.
Okay, so they squeeze the vessels in the nose. I'm with you.
But those drugs don't just stay in your nose. They go systemic. They go everywhere in your body. And where did we just say there's another massive concentration of alpha receptors?
The prostate.
The prostate.
Yeah.
So you pop 2 of those little red pills, your nose clears up beautifully, and then 4 hours later, you go to the bathroom to pee, and absolutely nothing happens.
Nothing at all.
Zero. You're standing there, you're straining, and nothing comes out. You are in acute urinary retention.
Wow.
Because that same chemical signal that told your nose to open up, told the muscle in your prostate to slam shut, you just gave your dynamic factor a massive jolt of electricity.
And now you're in the ER getting a catheter, all because you had a stuffy nose.
Yeah.
That is just wild.
It happens all the time. It is a classic presentation in emergency rooms across the country. But it's not just the cold meds. The text also puts up a big warning sign about drugs with anticholinergic effects.
Anticholinergics. Okay, these are the drying agents, right? I'm thinking things like Benadryl.
Exactly. Diphenhydramine, which
Oh,
is
yeah.
in Benadryl, and countless PM or nighttime formulas. Also some older antidepressants and some antispasmodics. Now, to understand why these are a problem, we have to bring in the other major player in this drama, the bladder.
Okay, so the prostate is the guard at the gate.
The bladder is the pump trying to push the fluid through the gate.
Perfect analogy.
The bladder is a big hollow muscle called the detrusor muscle. When it's time to urinate, a signal from your brain tells that muscle to contract, to squeeze, and that's what pushes the urine out.
Okay.
Now, anticholinergic drugs work by relaxing smooth muscle.
Wait a minute. That sounds like a good thing. We just said the problem is the prostate is squeezing too hard. Don't we want to relax it?
But that's the trap. You're right. But the anticholinergic doesn't relax the prostate. It relaxes the bladder. It weakens the pump.
Oh, I see where this is going now.
So if you have BPH, you already have a partially blocked door, right? That's the prostate. If you then take a Benadryl to help you sleep, you are essentially disabling the engine, the bladder, that's supposed to be pushing the door open.
So you have a blocked door and a weak push.
You've created the perfect storm. You're locking the door and turning off the engine at the same time. The result, once again, can be acute urinary retention. So if you're a man managing this condition, you really, really have to audit your medicine cabinet. That nighttime cold and flu combination pill could be the single worst thing you could possibly take.
That is such a vital, practical takeaway for our listeners. It's not just about the prescriptions, it's the stuff you buy yourself. But before we move on to how this all feels for the patient, let's nail down the culprit behind the growth itself. We've covered the dynamic factor, the squeeze. What's driving the static factor? Why does the prostate decide to start this population explosion in the first place?
The primary drivers that the source identifies are hormonal. It's a bit of a chemical cascade, really. We're looking at two main characters in this story. A hormone called dihydrotestosterone, or DHT for short.
DHT.
And an enzyme called type 2 5-alpha reductase.
Okay, so establish the relationship between those two for us.
Think of 5-alpha reductase as a little factory worker that lives inside the prostate cells. Its entire job is to grab testosterone as it floats by in the bloodstream and convert it into something else.
And that something else is DHT.
That something else is DHT. And DHT is like super testosterone, but only for certain tissues like the prostate and hair follicles.
So the more potent version.
Much more potent. It binds to the receptors inside the prostate cells, and it essentially sends one simple, powerful message: survive, multiply, grow. So as men age, even if their overall testosterone levels might be dropping a bit, this enzyme is still busy inside the prostate, cranking out this potent growth signal, DHT. And that's what keeps the growth engine running for decades.
So in a way, you've got this little factory on site, churning out the very fuel, the DHT, that drives the hyperplasia.
Exactly right. And that, as we'll see, becomes a major target for one of our main treatment strategies. But first, we really have to look at what all this growth and all this squeezing actually does to a man's life. We need to talk about the clinical presentation.
Right. When all these mechanics start to fail, when the static growth and the dynamic squeezing start to win, what does the patient actually experience? The text divides the symptoms into two really clear categories: obstructive and irritative.
And this distinction is really important because it tells us a lot about what's happening physiologically and how advanced the disease might be. The obstructive symptoms are the direct result of the pipe being narrowed. It's simple physics.
These seem pretty intuitive, the ones you'd expect.
They are. The patient experiences urinary hesitancy. That's that awkward delay when you're standing at the urinal waiting for the stream to finally start.
Right.
They might have a weak stream, or it might stop and start. They might have dribbling after they think they're finished. And a very, very common one is the sensation of incomplete emptying.
Because it is incomplete.
Exactly. They finish, they zip up, they walk away, and 5 minutes later, it feels like they have to go again because the bladder never fully emptied.
Okay, so that's obstructive. What about irritative?
So the irritative symptoms start to show up after the obstruction has been going on for a while, and these are the ones that really drive patients up the wall.
Why do we call them irritative? Is the bladder actually physically irritated?
In a physiological sense, yes. Think about the bladder muscle like a weightlifter. If the prostate is constantly blocking the exit, the bladder has to push harder and harder every single time you urinate just to get the job done. It's doing a heavy squat every hour.
So the bladder muscle gets bigger, it bulks up?
Yes, the bladder wall hypertrophies. It gets thick and muscular and bulky, but unlike a bicep, you do not want a bulky bladder. A bulky bladder loses its ability to stretch and hold urine gracefully. It becomes twitchy, hypersensitive.
That's on a hair trigger?
A total hair trigger. Even a small amount of urine stretching that thick, irritable wall makes the bladder spasm and scream, "We need to empty NW." And this leads to the classic irritative symptoms. Frequency feeling the need to go all the time, even if you just went. Urgency. That sudden, desperate panic that if you don't find a bathroom in the next 30 seconds, you're going to have an accident. And the big one, nocturia.
Waking up at night to pee.
Waking up 2, 3, 4, 5 times a night. And this is what destroys sleep quality. It affects your mood, your energy, your cognition the next day. Honestly, nocturia is often the breaking point. It's the symptom that finally brings men into the doctor's office.
And we shouldn't just gloss over this as an annoyance. The source material lists some really serious complications if this is left to progress, if it's left unchecked. It's not just about being uncomfortable. It can be genuinely dangerous.
Oh, absolutely. If the bladder can't empty properly, the pressure has to go somewhere. It can start to back up the ureters, which are the tubes leading from the kidneys. This can cause the kidneys to swell, a condition called hydronephrosis, and over time lead to chronic kidney disease and even kidney failure.
So you can actually lose kidney function because of a prostate problem?
You absolutely can. You can also get what's called gross hematuria, which is visible blood in the urine. The surface veins on the enlarged prostate are stretched thin and can rupture easily.
That must be terrifying to see.
It is. You can also get recurrent urinary tract infections because stagnant leftover urine is the perfect breeding ground for bacteria. And you can get bladder stones.
Bladder stones. How does that happen?
Imagine a pond that never fully drains. All the sediment just sits at the bottom. In the bladder, minerals and salts in the urine can crystallize out of that stagnant pool and form actual stones, which can be incredibly painful and cause more blockages.
Okay, so this is definitely something that needs to be diagnosed and managed before it gets to that point.
Yeah.
How is it diagnosed? The text mentions, the patient's history and then the physical exam.
Right. The history is really about capturing those symptoms we just talked about. There's a formal questionnaire, the AUA symptom score, that helps quantify how bad things are. But the physical exam is key, and it involves the digital rectal exam, or DRE.
The famous DRE, the glove and the lubricant. Now, obviously, this is the part of the checkup that most men dread. But from an anatomical standpoint, why is this the method? Why does it work?
It's purely a question of geography. The prostate gland sits directly in front of the rectal wall. They're immediate neighbors. So by inserting a gloved, lubricated finger into the rectum, a physician can actually palpate or feel the back surface of the prostate gland. It's the only way to physically assess the organ without, cutting someone open.
And what exactly is the physician feeling for?
They're assessing a few things. Size, for one. In BPH, it will usually feel enlarged, bigger than the typical 20 grams or so. But the texture is the most important finding.
Okay, so what does a classic BPH prostate feel like to an experienced examiner?
It should feel smooth, soft, and symmetric. The analogy that's often used is that it should feel like the tip of your nose. Or if you feel the fleshy part of your palm at the base of your thumb, that's called the nar eminence, it should have that kind of firm but rubbery consistency.
And what would be the warning sign? What's the texture you don't want to feel?
If it feels hard, if it feels like a knuckle or a piece of gravel or a rock, or if it's asymmetric, lumpy, and irregular on one side but not the other, that raises a massive red flag for malignancy, for cancer. Generally speaking, BPH is soft, cancer is often hard. That simple tactile distinction is why the exam is still so important, even in this age of advanced imaging and blood tests.
Okay, so let's say the exam is done. We've confirmed it's BPH. We know it's benign. We know it's causing symptoms. Now we have to figure out what to do about it. And the text outlines what it calls a strategy of management. And interestingly, the goal isn't always just fix it immediately.
No, not at all. And this is really where the art of medicine comes into play. The goals are very specific. 1, control the symptoms to improve quality of life. 2, prevent those scary complications we talked about, like kidney damage. And 3, delay the need for surgery for as long as possible.
And the choice of strategy depends heavily on how much the patient is actually suffering.
Exactly. And to measure that suffering, we use that AUA symptom score I mentioned earlier.
The scorecard.
It's the scorecard. It's a series of questions. How often do you have a weak stream? How often do you have to push or strain? How often do you get up at night? And you end up with a score from 0 to 35.
And how do we break down those scores?
0 to 7 is considered mild disease, 8 to 19 is moderate, and 20 or higher is severe.
Okay, so let's talk about the strategy for that mild group. The guy is scoring a 7 or less. The text calls the approach watchful waiting. Now, to me, watchful waiting sounds a little bit like ignoring it and hoping it goes away.
It sounds like that, but it's a common misconception. Watchful waiting is actually a very active process. It's not doing nothing.
What does it involve?
It involves active reassessment at regular intervals, usually every 6 to 12 months, to make sure things aren't getting worse and no complications are developing. But even more importantly, it involves active behavior modification.
So we're not giving pills yet, but we are giving homework. This goes back to lifestyle, right?
Exactly. This is all about managing the fluid dynamics. It's basic physics. If you drink a liter of water right before you go to bed, your bladder is going to fill up and you're going to wake up to pee. It's that simple. So the first piece of advice is to restrict fluids for a couple of hours before bedtime.
Simple enough. What else?
We look at bladder irritants. Caffeine is a double threat. It's a diuretic, meaning it makes your kidneys produce more urine, and it's also a direct irritant to the bladder wall, making it twitchier.
So it makes the problem worse from both ends.
Right. Alcohol acts in a similar way. So for many men, just cutting out that afternoon coffee or the beer before bed can have a massive impact on their symptoms, all without a single pill.
And I'm guessing we also tell them to stay out of the danger zone to avoid those over-the-counter drugs we listed earlier.
Absolutely. Rule number 1 is stay away from the Sudafed.
Okay, but let's say those lifestyle tweaks aren't enough. The symptoms progress. The score creeps up into that moderate range. The patient is miserable. Now we have to move to pharmacologic therapy. And this is where our understanding of the pathophysiology, that whole static versus dynamic factor thing, becomes the roadmap.
It's the entire roadmap. We have 2 main targets we can go after. We can target the muscle tone, the dynamic factor, or we can target the physical size of the gland, the static factor.
Let's start with the muscle tone. Let's start with the squeeze. These are the alpha blockers.
The alpha-adrenergic antagonists. The logic here is incredibly simple and elegant. If the alpha receptors are receiving the signal that causes the clench that's pinching the hose,
then let's block the signal.
Let's block the receptors. If we block the receptors, we prevent the signal from getting through. The smooth muscle in the prostate and the bladder neck relaxes.
And what does that achieve physically for the patient?
It opens the door. It increases the urinary flow rate so they have a stronger stream. It reduces the amount of urine left in the bladder after they go, the post-void residual or PVR. Essentially, the patient can pee much more freely and completely.
Now, here's a really crucial point that the text makes. Does taking an alpha blocker actually shrink the prostate?
No, and that is a critical distinction. Alpha blockers do not decrease the prostate volume. They do not change the natural history of the disease. They also do not lower PSA levels.
So they're not fixing the underlying growth?
Not at all. They strictly work on the dynamic factor, that muscle tone. They're a symptom treatment. They relax the fist that's squeezing the hose, but they don't make the fist any smaller.
Okay, so they relax the muscle. But it seems we have different generations of these drugs. The text talks about second generation versus third generation agents. And it sounds like the early versions had some interesting side effects.
Interesting is a very diplomatic word for it. The second generation agents, these are drugs like prazosin, terazosin, and doxazosin, are what we call non-selective.
Non-selective, meaning they don't just hit the receptors in the prostate.
Exactly. They block alpha-1 receptors everywhere in the body. And it turns out you also have a lot of alpha-1 receptors in the smooth muscle of your peripheral blood vessels.
And what do they do there?
They help maintain your blood pressure by keeping the vessels slightly constricted. So what happens if you take a drug that blocks those receptors?
Your blood vessels relax and your blood pressure drops.
Your blood pressure drops. The major side effect is orthostatic hypotension. That's that head rush or dizziness you get when you stand up too quickly. But the really scary one was something called first dose syncope.
Syncope just means fainting.
Yes. Patients would take their very first pill, stand up a little while later, and literally pass out cold, just drop to the floor.
That sounds incredibly dangerous, especially for an older patient population that's already at a higher risk for falls and fractures. A broken hip is no joke.
It is a massive risk, and that is why the text outlines a very specific, very careful titration schedule for a drug like terazosin. You can't just give someone the full therapeutic dose on day 1. You have to start low and slow.
I'm looking at the schedule here in the source. It says for terazosin, you start with 1 milligram at bedtime for the first 3 days. Then you go to 2 milligram for days 4 through 14, then 5 milligram, then finally 10 milligram. That takes weeks.
It takes weeks. And notice it specifically says at bedtime.
Why is that?
That's to minimize the risk of the patient getting dizzy and falling. You want the peak effect of the drug, the biggest drop in blood pressure, to happen while the patient is already lying down and hopefully sleeping. You have to slowly titrate up to let the cardiovascular system get used to this new lower pressure normal.
That just seems like a lot of hassle and a lot of risk.
Yeah.
Is that why the third-generation agents were developed?
It is precisely why. The goal was to find a drug that gave us the prostate benefit without the blood pressure liability. The third-generation agents, the most famous one is tamsulosin, brand name Flomax, and also silodosin, are uroselective.
Uroselective.
Meaning they are selective for the urinary tract. They specifically target the alpha-1A receptor subtype, which is highly concentrated in the prostate, while having much less effect on the alpha-1B subtype, which is the one found in the blood vessels.
So if terasosin is like a shotgun that hits everything.
Tamsulosin is like a sniper rifle that hits just the target.
That's a great analogy. So because they're selective, they have much less effect on blood pressure.
Much, much less, which makes them the ideal choice for patients who can't tolerate hypotension. Maybe they already run low blood pressure. Or, very commonly, patients who are already on multiple blood pressure medications for other reasons. You don't want to add another drug that's going to bottom out their pressure.
And I'm assuming you don't need that weeks-long complicated titration schedule with these newer drugs.
That's right. Tamsulosin allows for immediate therapeutic dosing. You can start the effective dose on day 1, and the patient can start feeling relief within a few days. It's the go-to for patients who just want fast, convenient relief without all the hassle and risk.
Are there any catches? Any major side effects with these newer ones?
Well, nothing is ever completely free in medicine. You do have to watch for certain drug interactions through the liver's CYP3A4 system. But broadly speaking, they are much better tolerated than the older generation.
Okay, so that covers the relaxers, the alpha blockers. They open the door, but they don't shrink the building. So now let's talk about the other strategy. Let's talk about the shrinkers. These are the 5-alpha reductase inhibitors, or 5-ARIs.
Right. So this approach targets the spatic factor, the actual size of the gland. And the logic here is, if the hormone DHT is the fuel that's driving the growth, let's just cut off the fuel supply.
And these are the drugs like finasteride and dutasteride. How exactly do they work?
They work by inhibiting that little factory enzyme we talked about, 5-alpha reductase. By blocking that enzyme, they stop the conversion of testosterone into the more potent DHT. Without DHT constantly stimulating the cells, the prostate actually begins to atrophy. It shrinks.
This sounds like you're actually getting at the root cause of the problem.
It is. This is the only class of medications that has been demonstrated to actually alter the natural history of the disease. They slow the progression. They reduce the long-term risk of needing surgery. Alpha blockers treat the symptoms today. 5-ARIs treat the disease process over the long run.
But there's a catch. And the catch is time.
A big catch. You cannot shrink an organ overnight. It takes time for the cells to stop multiplying and for the tissue volume to actually reduce. The source material says it takes up to 6 months to see the maximal effect, the maximal shrinkage.
6 months is a very long time to wait for relief if you're getting up 5 times every night.
It is an eternity, and that's why in practice for men with large prostates and significant symptoms, we often start them on combination therapy, an alpha blocker for fast relief, and a 5-ARI for long-term control.
That makes sense. But there's a very specific, and I would say very high-stakes rule associated with these shrinking drugs that we absolutely need to discuss. You called it the PSA trap?
The PSA trap. This is a vital piece of information. Anyone taking these drugs and any doctor prescribing them needs to understand this.
So walk us through it.
Okay. We all know that PSA prostate-specific antigen is the blood marker we use to screen for prostate cancer. PSA is produced by prostate cells. So, since 5-ARIs shrink the prostate and reduce the total number of prostate cells.
It makes sense that they would lower the amount of PSA in the blood.
Exactly, and they do. Typically, after about 6 months of therapy with a drug like finasteride, the patient's PSA level should drop by approximately 50%.
So if a doctor is looking at a lab report for a patient on one of these drugs, they need to do some mental math. They can't just take the number at face value.
They absolutely cannot. And this is where the trap is. Let's play out a scenario. You have a patient whose PSA was 4.0 before he started the medication. He starts finasteride. 6 months later, you check his blood work again, and his PSA is now 2.5.
Okay.
So the patient looks at the lab report and says, great, 2.5 is way lower than 4.0. The drug is working. I'm getting better.
But you're shaking your head. That's not the right interpretation.
It is the wrong and potentially dangerous interpretation because of the 50% rule. If he started at the baseline of 4.0, his PSA should have dropped to 2.0 after 6 months. The fact that it's only at 2.5 means that his real baseline, relative to the drug's effect, is actually rising.
Oh, I see. The drug is artificially suppressing the number, and it's masking a rise that's happening underneath.
Exactly. To get his true number, you have to multiply the measured PSA by 2. So his 2.5 is actually a 5.0. He hasn't gotten better. He's actually gotten significantly worse while on the drug. And that is a massive red flag for a potential high-grade prostate cancer that is growing despite the medication.
So the cancer cells might be ignoring the drug's hormonal signal and just growing anyway.
They're growing fast enough to outpace the drug's suppressive effect. The rule of thumb is crystal clear in the source. Any increase in PSA while the patient is on a 5-ARI, even if the absolute number still looks normal, must be viewed with suspicion and evaluated for cancer. You cannot take the number at face value.
That is a huge clinical pearl, a critical piece of information. Now, there is another warning attached to these drugs that's quite dramatic. The FDA has them as pregnancy category X.
Yes. Category X is the absolute strongest warning the FDA has regarding pregnancy risk. But usually that warning applies to the pregnant woman herself taking the drug. Here, the situation is a bit different.
Right. The text says that pregnant women shouldn't even handle the tablets if they're crushed or broken.
Correct. And the reason is profound. These drugs work by blocking male hormone activity. They stop the formation of DHT. And it turns out DHT is absolutely essential for the normal development of the male genitalia in a developing fetus.
So if a pregnant woman were to touch a broken tablet,
if she were to absorb even a small amount of the drug through her skin, or as some sources caution, potentially through sexual contact with semen from a man taking the drug, it could theoretically interfere with the normal sexual development of a male fetus. It could cause significant birth defects in the baby's reproductive system.
that is incredibly specific and very, very serious. It just underscores how potent these hormonal mechanisms really are.
They are incredibly potent.
Okay, so we have the relaxers, the alpha blockers, and we have the shrinkers, the 5-ARIs. But we live in a world where patients often have more than one issue at a time. What happens if a patient has BPH, but he also has erectile dysfunction, or ED? Is there a way to, kill two birds with one stone?
There is, as a matter of fact. The text mentions another class of drugs, the phosphodiesterase inhibitors, specifically tadalafil, which most people know by its brand name, Cialis.
Right, we think of Cialis purely as an ED drug. How does it help with BPH?
The mechanism is related to smooth muscle relaxation. It works by increasing levels of a chemical called cyclic GMP, and the end result is relaxation of smooth muscle. It turns out this relaxation effect applies not only to the blood vessels in the penis, but also to the smooth muscle in the prostate and the bladder neck.
So it's working on that dynamic factor, again, just like the alpha blockers, but through a different pathway.
Exactly. A daily low dose of tadalafil, like 5 milligrams, has been shown to improve voiding symptoms. The text notes that it doesn't necessarily produce a huge change in the objective flow rate number on a machine, but subjectively, patients report that they feel better. And of course, it's treating their ED at the same time.
That seems like a very practical and elegant solution for the right patient. Now, let's circle back for a second to those irritative symptoms. The frequency, the urgency, the bladder that thinks it's a gym rat. Can we treat the bladder directly?
We can, but it is a risky proposition. This is where we have to revisit the anticholinergic drugs.
Wait a minute. Didn't we just spend time earlier putting anticholinergics in the danger zone? Didn't we say they cause urinary retention?
You are paying very close attention. Yes, we did. And this is where medicine becomes a delicate art of balancing risks and benefits. We said earlier that anticholinergics can cause retention by weakening the bladder's ability to pump. However, if a patient's main problem is severe irritative symptoms, if their bladder is spasming and contracting all the time when it shouldn't be, we might want to give it a little something to relax it, to calm it down.
So you'd use a drug like oxybutynin to quiet down that twitchy bladder muscle.
Exactly. But, and this is a very, very big but, You absolutely have to check the plumbing first. The text is emphatic about this. You must measure the patient's post-void residual, the PVR, before you even think about starting one of these drugs.
What's the cutoff number?
The PVR needs to be less than 250 milliliters. Basically, you have to be certain that the patient is emptying their bladder reasonably well on their own before you give them a drug that's going to weaken the pump. If they're already retaining a lot of urine and you relax their bladder further, you will almost certainly push them into complete retention.
So it's a valid strategy for a very specific problem. But you have to check the data first.
You have to check the data first. It's not a drug you use lightly in this population.
Okay, so let's talk about the end of the line. If the drugs aren't enough, or if complications like kidney issues start to arise, we have to look at surgical options. The gold standard, mentioned in the source, is a prostatectomy.
Yes. Specifically, the most common procedure for decades has been the transurethral resection of the prostate, or the TURP.
Can you describe what's actually happening during a TURP procedure?
It's essentially an endoscopic roto-rooter procedure. A surgeon goes in through the urethra with a scope that has a small electrified wire loop on the end, and they use that loop to methodically carve out the inner tissue of the prostate, chip by chip, removing the overgrown tissue that's causing the obstruction.
So you're literally coring it out from the inside,
Yeah.
like an apple.
That's a great analogy. You're widening the tunnel from the inside out.
It sounds very effective.
Oh, it's highly effective at solving the plumbing problem. The improvement in flow is immediate and dramatic, but anytime you have surgery, anytime you're cutting tissue, there are consequences. And with the TUR, there is one side effect in particular that is extremely common.
Retrograde ejaculation. The text says it complicates up to 75% of these transurethral procedures.
75%. That is 3 out of every 4 men who have this procedure. It's almost an expected outcome.
Can you explain the physics of that? Why does it happen?
To understand it, you have to look at the normal anatomy of ejaculation. When a man ejaculates, there's a sphincter muscle at the neck of the bladder, right where the bladder and prostate meet. Normally, that sphincter slams shut.
So it closes the back door.
It closes the back door, forcing the semen to go the only way it can, forward and out the urethra.
Okay.
But during a TURB, the surgeon is intentionally carving away tissue right at that bladder neck to open up the channel for urine flow. In doing so, you often damage or remove the very mechanism that allows that sphincter to close tightly.
So after the surgery, the back door stays open.
The back door stays open, and fluids, as we know, follow the path's least resistance. So when ejaculation occurs, instead of fighting its way down the length of the urethra, a lot of the fluid just flows backward into the wide open space of the bladder.
Is that harmful to the man?
Physiologically, no, not at all. The semen just mixes with the urine in the bladder and is voided out the next time he urinates. It's not dangerous. But psychologically, and certainly from a fertility standpoint, it's very significant. The patient experiences a dry orgasm. It's something that men need to be explicitly counseled about before they consent to the surgery.
That is a massive quality of life consideration. Okay, and finally, before we wrap up the management section, I have to ask about the herbal stuff. You go into any health food store, any pharmacy, and you see bottles and bottles of saw palmetto. It's marketed so aggressively for prostate health. What is the verdict from our medical source material?
The verdict in this text is surprisingly blunt. It acknowledges that phytotherapy herbal remedies like saw palmetto, stinging nettle, African plum are all very widely used, particularly in Europe. But then the text states, and I'm quoting here, that they should be avoided.
Should be avoided. That is very strong language for a medical text, which is usually full of cautious phrasing.
It is very strong. And the text cites 2 main reasons. First, the large-scale, well-designed, rigorous scientific studies looking at their effectiveness have been, at best, inconclusive. We just don't have solid, repeatable proof that they work any better than a placebo.
And the second reason?
The second reason is perhaps more important. These products are sold as dietary supplements, not as regulated drugs.
So the quality control is an issue.
It's a huge issue. The purity of the product, the actual dosage of the active ingredient, the presence of contaminants, it can all vary wildly from bottle to bottle and brand to brand. You don't really know for sure what you're getting. So from the strict evidence-based medical perspective laid out in this source, they are not recommended.
Good to know. Save your money for the treatments that actually have solid data behind them. Okay, so let's try to bring all of this together. We have unpacked a tremendous amount of information here. We have the anatomy, the hormones, the relaxer drugs, the shrinker drugs, the surgery. If you had to summarize the game plan for a listener who's dealing with this, how does the progression generally look?
The progression is very logical and it's stepwise. For mild cases, you start with watchful waiting, and those lifestyle modifications, master your fluid intake, cut the caffeine. If and when symptoms start to really impact quality of life, you move to medication.
Okay.
You'll likely start with an alpha blocker, like tamsulosin, to relax the muscle and get immediate improvement in flow. If the prostate is particularly large, you might add a 5-ARI, like finasteride, to shrink the gland over the long term, accepting the side effect profile and the time delay.
So you might use both at the same time.
Very common to use both. And then if the medications stop working, or if complications develop, or if the side effects are intolerable, that's when you move to surgery to physically clear the path once and for all.
And throughout this entire process, the primary metric we're tracking, the main goal, isn't just a number on a flow rate chart.
No, absolutely not. The text explicitly states that the most important outcome is the patient's perception of their symptoms. It's about their quality of life. That AUA symptom score is our guide. We are treating the patient, not just the prostate.
I think that's a fantastic place to land. But there is one final crucial reminder in the outro of our outline. And that's about the annual exam.
Yes. This is so important. Even if your symptoms are perfectly managed, even if you're on medication and you feel great, the digital rectal exam and PSA screening remains standard recommendations for men with a life expectancy of at least 10 years.
And why is that?
Because BPH is benign. But having BPH does not in any way protect you from getting prostate cancer. There are two completely different diseases that just happen to live in the same forest. You have to keep screening for the dangerous one, for the cancer, independently of how your BPH symptoms are doing.
So don't skip the checkup just because the flow is better.
Do not skip the checkup.
Well, there you have it. The deep dive into the mechanics of benign prostatic hyperplasia. It is so much more than just an inevitable part of aging. It's a dynamic interplay of muscle and hormones and tissue that can be understood and can be managed with a really intelligent, stepwise strategy.
It really highlights how understanding the why, the receptors, the enzymes, that quirky evolutionary design, it gives us the power to change the how we experience living in our own bodies.
Thank you so much for joining us on this deep dive. Hopefully you'll never look at a cold medicine aisle or, for that matter, a prostate quite the same way again.
Probably not.
We'll see you next time.